Good morning teachers, seniors and batchmates. Today I am presenting slide number 5. History given was 32 years female with enlarged lymph node papules present on the scalp. This was the image provided. Here we can see sheets of mononuclear cells with round to oval hyperchromatic condensed nuclei. Amidst are seen thick and thin walled proliferating vascular channels surrounded by mixed inflammatory infiltrate predominantly composed of lymphocytes and plasma cells with some eosinophils. The endothelium of the vascular channels show vesicular nuclei with vacuolated acidophilic cytoplasm. Also seen are some dilated, congested blood vessels. Diagnosis was angiolymphoid hyperplasia or angiolymphoid hyperplasia with eosinophilia. Coming to review of literature, angiolymphoid hyperplasia with eosinophilia is an uncommon vasoproliferative idiopathic condition that manifests in adults as isolated or grouped papules, plaques or nodules in the skin of the head and neck region. This lesion is also known as epithelioid hemangioma, histoid hemangioma, angiomatous nodule, pseudopyogenic granuloma and inflammatory angiomatous nodule. Commonly seen in young to middle-aged adults, affects female gender more than male. Asian originates are more commonly affected than Caucasians. Common sites are predominantly seen on head and neck region. Other sites noted are trunk, extremities, hands, penis, oral mucosa and colon. Etiology. No definite etiology known so far. Most probably etiology thought are a reactive process, infectious etiology, immunological process or neoplastic process. Clinical features. Patients usually present with single or multiple flesh to plum colored papules or nodules ranging in size from a few to several centimeters. Some patients may experience tenderness, pulsation, pruritus, bleeding either spontaneously or after minor trauma. Peripheral blood eosinophilia and regional lymphadenopathy may also be seen. These are some of the clinical pictures of the patients with angiomatous hyperplasia with eosinophilia. Here we can see nodular lesions in the scalp, erythematous nodular lesion. Here we can see coalescing nodules in the scalp. Macroscopy. Macroscopy shows proliferation of vascular channels with accompanying mixed inflammatory infiltrate seen as nests and cords of endothelial cell proliferations with admixed lymphocytes, plasma cells and eosinophils, accompanied by hemorrhage and proliferation of thick and thin walled blood vessels. Endothelial cells show large vesicular nuclei with acidophilic and sometimes vacuolated cytoplasm, imparting a hobnail appearance. Mitosis can be seen but lack atypical features and anaplasia. Differential diagnosis of angiomatous hyperplasia with eosinophilia are angiosarcoma, epithelioid hemangioendothelioma, Kaposi sarcoma, Kimura disease or pyogenic granuloma. Coming to first differential, that is angiosarcoma. Here numerous irregularly shaped anastomosing vascular channels lined by atypical endothelial cells with highly infiltrative architecture and poor demarcation is seen. Tumor cells are typically plump, pleomorphic and mitotically active. They can be spindle-shaped, polygonal epithelioid and primitive round cells forming papillae or solid nests within vascular lumina as seen here. Pleomorphic cells are seen in this type of angiosarcoma. Intratumoral hemorrhage is common. Stromal lymphoid aggregate may also be seen. Coming to the second differential, that is epithelioid hemangioendothelioma. In this, cords, strands or small nests of large endothelial cells with abundant eosinophilic cytoplasm embedded in mixed hyaline stroma is seen. Tumor cells have vesicular, round to oval, sometimes indented nuclei. Some tumor cells have intracytoplasmic round clear vacuoles representing small vascular lumina which may contain erythrocytes. Coming to third differential, that's Kaposi sarcoma. This is vascular neoplasm caused by human herpes virus 8, commonly seen in immunocompromised individuals. Common sites are lower extremities, and macroscopy shows discrete nodules composed of intersecting fascicles of uniform spindle cells, intervening blood-filled spaces between spindle cells, slit-like spaces, longitudinal section, as we can see here, sieve-like spaces in cross section, and intracytoplasmic hyaline globules may be seen. Coming to next differential, that is Kimura disease. In this, there is disruption of follicles by increasing eosinophils causing follicular lysis as seen here. There is hyperplasia of follicles with the disruption of follicles, that is folliculitis, by proliferating eosinophils. Proteinaceous material may be present in germinal center due to increased immunoglobulin E deposition, admixed with polymorphous population of lymphocytes, plasma cells, mast cells and histiocytes. As we can see here, mixed population of inflammatory cells. Polykaryocytes of Warthin-Finkelday type may be present. Vascular proliferation in interfollicular areas is seen. Here in between the follicles, we can see vascular proliferation. Necrosis and varying degree of sclerosis may be seen. Hyperplastic follicles with germinal centers associated with expansion of interfollicular areas by abundant eosinophils, often forming eosinophilic microabscesses. This is another differential, pyogenic granuloma. It is fleshy cutaneous tumor often seen on fingertips and lips. Microscopy shows lobular pattern of vascular proliferation with inflammation and edema resembling granulation tissue. As we can see here, it is well circumscribed lesion. Lobular pattern of vascular proliferation is seen. Thin epidermis at the top, as seen here. With variable ulceration, acanthosis and hyperkeratosis at the sides may be seen. Central branching vessels with no or rare red blood cells surrounded by endothelial cells. Here these are the endothelial cells. Variable mitotic activity may be seen. Deep lesions often lack edema and inflammation. Thank you.